Let's begin with our next session. And to moderate this session, may I please invite Dr. Tarjani Dave, our chairman, Dr. Gagan Dudeja, our co-chairman, Dr. Tipil Switi, and our conveyor, Dr. Shruti Tara. Over to you, moderators. Dr. Tarjani Dave, do we have you over here? Okay. The fact that she's not present over here, I'll take over. And may I please invite our first speaker, Dr. Jayanta Das. Dr. Das, are you there? Okay, fantastic. Doctor, we can start screen sharing and please unmute your mic.
Good afternoon, everyone. So that's my topic is enucleation versus evisceration. When and how. Generally, for the general public, it is enucleation is a removal of the total removal of the eyeball, entire eyeball. In true sense, the loss of eyeball, yes. But is it destructive? No. And most of the time we can go for we can use it as a constructive surgery also. Is it a minority procedure? The answer is no. It's a need a lots of skill for that. Next, what is actually evisceration? It is a surgical removal of the content of the eyeball, not as a whole eyeball. So generally we can preserve the sclera is a common type, but nowadays we can use the cornea sparing techniques also. So that's time is I want. So for in some, especially in injured patient, in traumatized, especially traumatized patient, it is very, very difficult to convince. In such cases, cornea sparing is one of the best options. Again, it is not a destructive procedure. We always prefer it is a constructive procedure, not a minority procedure. Or it mostly it is a cosmetic surgery for us in most of the time. So why we can consider it is a cosmetic surgery? Possible for proper volume replacement because we can equalize the volume. Almost symmetrical look. I am not saying that symmetrical, almost symmetrical, good movement, special custom-made prosthesis, and in cornea sparing technique is very, very informative. But as it was in my talk, it was a why and when. So choice-wise enucleation versus inversion. It just remain controversial in certain circumstances. Those are some published reports are there, but most of the reports now in trans like that. As the sympathetic option is less, so we can go for a evisceration also. Evisceration is relatively simple. We may go for a transscleral implant or we can go in a scleral quadrification, but this is mandatory nowadays for better cosmesis. We can implant the ball proper size blood with proper technique. This is a very much important this. So as I mentioned, we can go for a standard evisceration until and unless there is some medical problem, then most of the time we can go for along with the primary evisceration implantation, there's a ball implantation. There's lots of techniques. We may go with standard evisceration technique with relaxing incision. We can make a posterior cut and we can go for a 4-quadrant technique, we can go for a transcleral technique, whatever. Our aim is to just do a better cosmesis. On the other hand, in that enucleation, as it is total removal of the eye, there's a lots of other material we can implant the ball in the cone itself without any suturing, without any that material. But sclera is the one of the best to cover, and we can suture all the muscles for better cosmetic look. So one of my patients in a small, she was due to the injury, evisceration was done, and I just open up the sclera and then a implantation done, and this is the good socket and this is the look. In evisceration and implant is placed within the sclera. As I already mentioned, there may be so many relaxing posterior sclerotomy or might be standard techniques, but in enucleation, we need one other material like a sclera or other materials. Or without the ball, sometimes perforated ball we can implant, but this is mandatory for each and every patient to go for. One, evisceration and evisceration, there is some controversy. One very important point is sympathetic ophthalmia. Earlier, in the era 20 years or 30 years back, there was a high incidence of sympathetic ophthalmia following trauma. That time, probably the medical facilities was not as good as, and steroid was not used most of the time. And that's why there was some sympathetic ophthalmia. But now in today's era, the sympathetic ophthalmia is very incidence is very low. Or even there is a sympathetic ophthalmia, we can treat the eye very easily. So in such cases, so better we can go for a evisceration rather than enucleation. And another point is the motility and cosmesis. There is a lots of debate on motility and the cosmesis, but there is some studies that Nakra, T, Ben et al. Etc. They are studied 84 patients in a very meticulous way. As per them, there is no such gross difference. They are telling us not gross difference. But however, these claims cannot be made based on the retrospective analysis. Points against eviscerations are, but there is some indications where there is a points against. Those are some technical. One is scarred orbits or thysis bulbi, but I am at present doing in thysic bulbi, so it's a modified technique with evisceration. But some are definitely, there is some definite contraindication like intraocular tumor, suspected malignancy, diagnostic and research purpose. For diagnostic and research purpose, generally we need a enucleation is better for doing SPE. But whatever the way we want to do, we must do a implant, primary or either it may be a secondary, but primary is always better. Options remain variable when considering enucleation versus eviscerations, primary versus secondary, implant. Placement is depending on the situation. Generally, this is a mandatory process. This is a little bit about that. There it may be a non-integrated or it may be integrated or it may be autogenous. But nowadays, with non-integrated is very useful, is cost effective, and it's very rewarding. So then next is that we can go for, as I mentioned, it was a long back evisceration was done. So in such cases, we can go for a donor sclera and we can use it. And those are some surgical steps. We can open up the conjunctiva. We can meticulously open up the tenons. Then we can use a eye bank sclera and we can implant the ball inside, suture it, and we can implant like a ball. And it was the earlier socket. This one, the next socket, where it is very good. There is a shallow, there is a deep socket superiorly, shallow in the inferior, uneven socket. But with implant, we can modify some amount. We can superiorly we can push it, and we can reduce the sulcus deformity, and ultimately there is a ideal. But though it is an ideal socket, but that here is not the sizes are not as equal. So need a proper prosthesis. But the main advantage of ball, which those are a porous ball earlier, that is, if we are implanting little bigger size, there is a chances of extrusion, expulsion. If there is a infection following the operation, there may be some extrusion, exclusion. Those are the important in both the conditions. It may be in following in evacuation, following enucleation. But as I already mentioned, our work is up to the surgery. But the role of ocularists is very, very essential. These services may include cleaning, polishing, enlargement, reduction, and replacement all. So we can proper size, we can maintain and we can prepare like it. And there is some which is not possible to cover up all sides. So suppose in this old patient, yes, he features some down long back, huge sulcus defect, shallow fornix, also we can manage in such a way. So get better cosmesis. So occupational rehabilitation is one of the very, very important component following evisceration and enucleation. So the eye care provider should provide a affordable artificial eye to the patients as a very essential component of rehabilitation. But it is not, I always against the stock eye is generally decreased. One of the lady, evisceration was done, so she just maintained her hairstyle and just that one. And with that secondary ball implant, it can be easily managed. So, aesthetic point of view, though few studies said that there are no difference between enucleation and evisceration. However, there was an overall trend that evisceration patients has a better subjective scores in fornix and sulcus appearances than enucleated patients. So, in my take-home message, the decision is largely based on surgeon's preference and the experience, with evidences, literature, other supports. So basically, frankly speaking, evisceration is slightly easier process, and most of the time we can perform in general anesthesia. For the cost-effective point of views, suppose in young age, maybe 16 years to 18 years, in some patients, it is very, very difficult to convince enucleation, psychological point of view, and to convince inside the OT under local anesthesia. So this is another important factor in our country, like where socioeconomic condition is one of the factor. In such scenario, we can go for. I prefer specially evisceration over enucleation is a low incidence of sympathetic abnormality in today's era. It is already proved and comparatively easy and better in terms of cosmesis. It is easy in the surgery over the enucleation. And cosmetic point of view, as lots of other authors also mention, it is easier for this. So, thank you.
Thank you, Dr. Das. Our moderator, Dr. Tarjini, has joined now, so
Yeah.
she'll be taking over. Yeah, thank you, sir.
Thank you, Dr. Jayanta. That was very illuminating on when and how to perform evisceration. And I think we can't emphasize the fact about placing an implant more. While I just try to open up the program, I'd invite the next speaker on board. Rutuja, do you have the list of speakers?
Ma'am, I do have it. If you...
Yeah, it's there, ma'am.
Okay, so I would like to invite our next speaker. Please welcome Dr. Feroz, PM.
Okay, Feroz is not here.
No, Dr. Tarjini will be doing that talk.
Yeah, we'll do it in the end, Rutuja. We'll go ahead.
Yes.
This talk. So if
Yeah,
Sabri
Dr. Savri is there. Yeah.
Hello.
Yes, doctor.
Hi.
You're audible, you're visible, and may I please ask you to start screen sharing?
Rajini, you're taking the talk last?
Yes, Sabri.
Okay. So I'll
There
share
was
my screen then.
Yeah, please. There was a last minute change in the plan.
Yeah, I think someone will just have to remind my fellow. He's already online, I think. Just because he thought he was last. Okay, so I'm just sharing my screen. Is this seen?
Yes, doctor, visible.
Thank you. Where's the timer? It will come on, right? Once I start.
Yes, doctor, it will commence once you start.
Okay. So thank you everyone for giving me opportunity to speak and Feroz excellently planned day today. So I will be speaking on implant exposure.
Yes, doctor.
So I thought we would go in sequence. So this was what was written. I can't see the timer. Okay, got it. So basically, so far we spoke about different types of surgeries which Dr. Jayanta spoke about, and well, to summarize, we have to put an implant, which is inevitable, whether it's non-integrated or integrated, which gives rise to a good fitting prosthesis. And hopefully we think that the story ends there, but often we don't know what lies beneath. So if we were to take away and just see this boy, he looks like he has a good cosmos with a well-fitting prosthesis. But once you remove it, this is the actual picture showing an implant exposure. So what is exposure? So well, exposure means different things to different people. But I actually really like this definition, which is recently published by Dr. Tarjani, which talks about it being a loss of integrity of anterior tissues, conjunctiva, Tenon's capsule, sclera, such that the implant is visible on the surface. And any dimension of gaping is considered as exposure, including extrusion of the implant. So, one sec, sorry. So the implant exposure is different based on the type of implant. So when you talk about a non-integrated, basically there is no fibrovascular ingrowth. So the exposure is direct. There's nothing to retain the implant and it immediately extrudes. Whereas porous implants, they have fibrovascular growth. So the implant gets retained. So you see an exposure instead of a direct extrusion. The rates primarily as such in the literature were said to be 0 to 3% for non-integrated and 0 to 50%. However, the more recent literature, which I'll come to, does not show much differentiation. So what is the mechanism that causes this? It's inadequate or poor closure of the anterior layers, a wound breakdown due to excessive tension, such as maybe placing a large implant, and infection or post-op trauma. But commonly you see late exposures primarily in porous implants. This is because of the mechanical irritation inducing an inflammation, causing a tension on the anterior surfaces. Also, sometimes there could be delayed ingrowth of the implant, hence causing a breakdown of the tissues, and a poorly fitting prosthesis, which provides pressure. Now, there are various factors also which deal with the causes, such as these. And one of the longest term studies, which was done between porous implants, said that evisceration technique and pegging was one of the main statistically significant causes. However, in more recent literature, evisceration has not shown to be a factor. In this particular paper, they found that posterior sclerotomies were one of the main causes for evisceration being a statistically significant factor for exposure. Pegging is not done so much in our country, so it's not so relevant. But again, going back to Dr. Roshni's article, this was a case control study, which is probably a more defined study. And they found that whether it's an infection, multiple prior surgeries, or porous implants did not really have a significant, it was not statistically significant, or it did not matter for the exposure rates. So just to summarize, porous implants are known to cause more exposure. If you don't wrap a porous implant, whether it's with, donor sclera, then it will still have higher chances of exposure. Pegging has a higher chances of exposure. Posterior sclerotomies and evisceration may have higher chances. But endophthalmitis trauma being the causes for evisceration or enucleation is not necessarily a cause for exposure. So you can see them either less than a year, within 1 to 2 years, or over 2 years. So how do they present? So non-integrated implant will often present like this. You can see that the implant appears to be bulging. There is a little blackish area, which is the PMMA implant showing through the conjunctiva because the sutures have given away. So this girl is a case of mine. And probably my first case where a suture gave away and she didn't realize it. We don't know why. The implant was a 20 millimeter implant placed, and it basically migrated anteriorly and was going to come out. Then porous implants show sometimes significant congestion discharge, and these need to be cultured often, though they come negative. You will also see pyogenic granulomas, which are not resolving. This patient of mine had a pyogenic multiple, these are actually less after treatment, was being treated elsewhere and had them for 6 months. So you should consider an orbital implant infection. So case-wise, if you were to look at it, implant exposure in a non-porous implant, yes. So if it's a wound gape in the very early stages, you could maybe consider refreshing the edge and resuturing if it's possible, or augmenting it with an AMG, which can be a little tricky. You may need to double fold the AMG and suture it if it's a very small gape, or consider using an MMG. And if it's extruded, then you need to consider plan an implant exchange. Coming to a 27-year-old lady with a history of blunt trauma 10 days prior, I had done a 4-petal evisceration 7 years ago, and she had no complaints. And this was a case of domestic abuse. And the implant came out, and you can see the gaping hole. We put a conformer, but by the time she came to us, it was already 10 days. There was a lot of discharge and the socket had contracted, the shell had contracted. So we just let her heal. The cultures came negative for any organism. And after a period of 3 weeks, I planned to do a secondary non-integrated implant with a possibility of MMG. However, I could put a good sized implant. The initial one was 21. We managed to put a 20. We had to dissect the scleral shell out, which came out well, but you can still see some amount of puckering with a little bit of shallowing in the superior fornix. However, I chose not to do an MMG because I could put a good sized implant. So yes, in a porous implant, if there is exposure, you can broadly divide it into 3 categories. An MRI should be considered to know the vascularity of the implant. So in small exposures, you can consider a conservative treatment, where basically less than 3 or 5 millimeters, you have to observe it, give antibiotics, sometimes antibiotics with steroids. You may need to ask the patient to remove the prosthesis or get a vaulted artificial implant, which can be modified. And they do often close. It may take a little time, but sometimes from 6 to 12, 10 weeks or 12 weeks, they do close. Whereas moderate implants, you could try with conservative treatments. However, if it's not cured, then you need to consider either different materials such as temporalis fascia, which I have never tried, retroauricular periosteal flaps, which do very well, as explained in the literature, tarsoconjunctival flaps, which has also worked well in my hands, and mucous membrane grafts. However, large implants, which have not resolved, and you may have even tried conservative treatment, may require an implant exchange with an implant removal with or without a DFG or a dermis fat graft. So here's a patient with a moderate to large sized exposure. She was 18 years old, treated for retinoblastoma, and radiation was given. And this was when she was about 1.5 years, 2 years. So she came with this exposure with a lot of discharge. Again, we got nothing on the culture. However, we decided to do her MRI, and she was very unwilling to do an implant removal. So we decided to do an MRI, and the MRI did show that there was significant enhancement of the implant, especially in the anterior and the mid thirds of the implant. And you can actually see this very nicely on the MRI with the contrast. So we decided to do an orbital implant drilling to decrease the surface of the implant and put an MMG and also double line it with an amniotic membrane graft. So post-op at 1 week, she started developing, once we tucked in the MMG, we started developing at 1 week to 4 weeks, she started developing these buds growing from, as you can see, the mucous membrane and the AMGs are dissolving, but she started developing these buds at the edge of her own conjunctiva where the MMG was tucked in. And at 6 months, the entire thing had healed. Now it's almost a year follow-up and she is maintaining. She had a very micro opening of about 1 millimeter at around 9 months, which again spontaneously healed. And now she's been like that. So coming to a large exposure such as this was a 33-year-old lady with a wearing a prosthesis since he was 16 years when this surgery was done. And she got injured when she was not wearing a prosthesis and felt a small lick. And, while she was playing with a child, and she said that after that, there was discharge since a month. She came from out of India, and the reason I'm mentioning that was we didn't have a lot of time, and she was not keen on, again, removing the implant, which I was keen on doing. In fact, I wanted to directly go in and do a DFG. Her MRI showed that there was a very low uptake of contrast within the implant. So we decided that we would debride it, which we did, and we did a tarsoconjunctival flap from the upper tarsus. And I do not have photos because this was done many years ago. But what I did have is, this is how it, so we took a tarsoconjunctival flap from the upper eyelid, and we got these islands of tissues, which eventually never went on to completely heal, but did remain like this and stopped her from getting discharge and gave her comfort. And we made a new vaulted prosthesis, and this was her last follow-up picture in 2018. Coming to a large porous implant, this patient, actually, we didn't really ended up explanting the implant, though he never resolved and kept having this discharge and congestion and continued to wear his prosthesis. But I've just put this picture that ideally I would have liked to do a dermis fat graft, as was seen in this contracted socket, in which a dermis fat graft was done. I'm not going into details about this, as we will be coming to it later. To summarize, implant exposure, porous and non-porous implants may have a similar rate of exposure. But if it is unwrapped, then definitely porous implants tend to have a higher chances of exposure. A long-term follow-up is necessary because most of the porous implants tend to show exposure following only a year and go all the way up to 2 years. So you should have a follow-up for patients who you've operated with the porous implants. Placement of the implant should be as posterior and should be covered in 2 layers. And finally, what most of the papers have come to the conclusion is that whatever surgical technique you do, the surgeon's preferred surgery technique is the final role which plays the rate of exposure. Thank you.
Savri, excellent presentation. Are you able to hear me?
Yes.
All right. I think you are okay. So just one question for you. Do you, in your practice, use serum drops for exposure over porous implants? And have you seen any benefit with serum drops?
No, I have not used it, but of course we do know of it. And I think in the last meeting which we have, physical meeting which we had of socket in 2019, we did talk about this with Sweetie organized, and we did find that there is a possibility that those do enhance spontaneous closures and small to moderate exposures. And I would definitely consider trying it.
Right. And when you use, say, dermis fat grafts for porous implant exposure, do you sort of tend to also look at a technique where you've shaved off the implant and then place the dermis fat graft piggyback over the implant? Or is it always that you look at exchanging the porous implant and then placing a dermis fat graft?
So I've never tried that, Tarjini, but I would be willing to do it if the MRI shows that there is reason to salvage the orbital implant and provide volume. So in my hand, dermis fat graft works really well. So if I can remove the implant, I would be happy to remove it and maybe do a secondary implant, like a non-porous implant, after I've done a DFG, possibly.
Right, right. Okay, thank you so much, Savri. So I think we can, are we taking questions now, or we are waiting for questions from other panelists and taking it towards
we are actually short of time. So first of all, we'll be trying to complete the presentations, and then if time permits, we'll go ahead with questions.
All right. So if you could please introduce our...
may I please invite our next speaker, Dr. Roshmi Gupta.
Hi.
Dr. Gupta, do we have you here?
Hello. Am I audible?
Yeah, Roshmi, you're audible. So we now have Dr. Roshmi Gupta from Narayan Netralaya. Roshmi, can you hear us?
Yes.
Perfect. Ma'am, may I request you to please start screen sharing?
Yeah, Roshmi, your slides are visible. So we will have Dr. Roshmi speak to us on contracted socket and its management. Over to you, Roshmi.
Thank you, Tarjini, and thank you to the AIOS Scientific Committee for this opportunity to be with you here today. So we are going to be talking about the contracted socket or timely and precise management.
क्या तेरे को सही में लगा कॉल है जबरदस्त मतलब तू मेरी लेने कोई आता है
Define a contracted socket.
माँ की तुम्हारे
Orbital tissues
सुबह से
leading to decrease in depth of fornices
लगा
and
के रख दी
orbital
तेरे।
volume, ultimately ability to retain a prosthesis, and
तेरे बटन निकल
it is
आता है बीच में
accompanied
जाता
by
है अंदर कोई
conjunctival scar formation. Let us remember that this differs from the PES, post-enucleation socket syndrome. So if you look at the classification of contracted socket, class 1 is the patient who have only insufficient lining, that is only a surface deficit. Class 2 have surface as well as volume deficit, insufficient socket lining and deficiency in soft tissue. And class 3 are also deficient in growth of periorbital tissues and bones. So look at the examples. So this is an example of a patient with insufficient lining. This is a patient with insufficient surface as well as insufficient volume. And this is a patient with insufficient surface, volume, and a bony contracture. The Gopalkrishna classification talked about gradation, one or more fornices being involved in sequence. So one fornix shortening and then loss of upper and lower fornices, and then all four fornices, and then reduction of palpebral aperture. So in my opinion, this classification, while it addresses the basic tenet of contracture or fibrosis, it does not address the volume. A socket can undergo contracture for various factors. It can be a pre-op factor, trauma, chemical injury, previous surgery. It can be a per-op factor, poor technique, lack of implant placement, or multiple surgeries. Let's remember that if we do more and more socket surgeries, the greater the chance of contracture happening. And post-op factors such as radiation, poorly fitting prosthesis, and prolonged removal of prosthesis. A poorly fitting prosthesis, such as a rough surface, one that causes chronic irritation, and when you remove it, there's already an underlying level of inflammation. So if you remove it for some time without putting in a conformer, you'll see that within days, the entire socket can contract. A post-enucleation socket syndrome is, of course, where you don't place an implant after surgery, and the entire orbital tissues tend to rotate down, back, and then forward, and therefore fill up the inferior fornix. So a contracted socket and an orphan socket can coexist in any combination. And as we mentioned, a prevention of a contracted socket, part of it would be, if it is an infected socket, remove the prosthesis, start topical steroid and lubricant. An antibiotic cover can be there, but the main pathology is not infectious. And we place a conformer at the same time and change to a new customized prosthesis. When we plan for a socket management, if there's a fornix loss, we ask for a fornix formation suture. A surface deficit, we would ask for a mucous membrane graft. A plain volume deficit, we would ask for a secondary implant. And a surface plus volume deficit, we would ask for a dermis fat graft. This is an example of a patient who had only a fornix formation done. This should play. Okay. So we are using a 240 belt buckle as a stent in the inferior fornix, and we use a 4/0 braided suture, either silk or vicryl, because the braiding is going to cause the fibrosis. And as we pass it through the conjunctiva and through the periosteum of the orbital rim, because we want strands of fibrosis happening from the lower fornix to the periosteum. And when you place the conformer after that, you have to make sure that it is flat. It's not tilted in any way. Only then you're sure that both fornices are equal. You could combine a secondary implant and a fornix formation. In case you can see this deep superior sulcus, which indicates a loss of volume, which would give you a good result. And the third one is a loss of surface and volume, where you'd want to put a dermis fat graft, which gives a decent result. We measured the size of the gap and then oversized the dermis fat graft by about 20 to 30%. We inject a local anesthetic just below the epidermis, intradermal, to give us the pudiorange appearance. And then we shave off the epidermis. The pinpoint bleeding points tell us that we are at the correct depth, and that is the dermis that is visible. We harvest the graft, and this particular surgery is from the gluteal region. Close the donor site, and we place the graft into the gap and secure it. We secure the muscles to each corresponding edge of the graft and suture the conjunctiva around the edge of the dermis. One of the benefits of putting a dermis fat graft is that, for example, in this child, we placed a dermis fat graft, and 4 years later, we find that there's no volume loss. As the child has grown, the graft has also grown. In this particular patient, you'll see it's a severely contracted socket post-irradiation elsewhere. So after putting the dermis fat graft, we also added on a cosmetic optics, that is, used a convex lens to give the eye a more prominent look. One of the most difficult kinds of sockets are the chronic fibrosed sockets. This could be post-radiation. It could be a post-chemical injury. So, for example, this patient came to us with the prosthesis just sitting on the edge of the orbit. After surgery, we could fit a good prosthesis. However, within 1.5 months, we could see it started to shallow again. You'll see here the prosthesis is just about sitting on the edge of the palpebral fissure. So here we know that the culprit is the subconjunctival fibrosis. This patient underwent an injection of 5-fluorouracil. We placed a conformer and we did a marginal traction tarsorrhaphy to pull the eyelids closed and so in effect enlarge the surface. At a 24-month follow-up, the patient retains the prosthesis well. In a post-irradiation socket, you know that the blood supply is low. So the dermis fat graft has been placed, but a good bit of it has atrophied. So that's how there's a sunken appearance. This lateral canthal rounding, once again, is there. And you can actually make out that the bony orbit here is actually contracted compared to the other side. These would have needed possibly greater degree of surgery, but the patient was satisfied with this, and that's how we stopped here. So the take-home message is that the contracted socket is a result of combined mechanical and biological effects, and analysis and planning help to achieve optimal results. Thank you.
Thank you, Roshmi. That was a very detailed management of contracted sockets. So I just have one question for you at this point of time. So when you look at the surface area, and that's what you primarily spoke about, eventually do you also analyze the eyelids in the same sitting? And if you see some amount of entropion, then how do you go ahead and handle those eyelids? Do you sort of take care of the surface area and the eyelid in the same sitting, or you have some other strategy for that?
Sometimes, because I agree that the entropion is a function of the generalized contraction and fibrosis of the surface. Sometimes it may happen that if you've adequately replaced the surface, at least part of the entropion corrects. If it does not correct, and if it is cosmetically significant, we can go ahead and treat it in the form of a cicatricial entropion. That would be its category. But let us also remember that this entropion is something that it becomes a vicious cycle. If there's an entropion, the lashes themselves keep rubbing on the socket surface. So that in itself can cause further inflammation and further contracture. This is once again a mechanism we need to remember.
Right. Thank you so much. So in the interest of time, we'll move on to the next talk before we have the case presentation with Rahul. And this is going to be the talk that Fairuz was supposed to make, and I'm taking her place here. So it's titled as Implant Never Say No. So essentially, I'm Dr. Tarjini Dave. I work at LV Prasad Eye Institute, and I have no financial disclosures to make. You will see certain full face photographs of my patients for which we have consent. And the main objective today is to take you through certain aspects of implant in socket surgery via 10 case examples that I'm going to show you. So the points I'm going to talk to you about are why we use an implant, the metrics to assess the volume of the socket, what is post-evisceration socket syndrome that Roshmi and Sabri to a certain extent have already covered, how we size an implant, what do you do when in the primary sitting, and how differently can you manage the volume in secondary sitting, what are the options that you have, what is the management paradigm, and finally, already the complications related to implant have been covered by Sabri. So that's going to be one very brief topic. So when you look at socket surgery, this is the sort of outcome that you want at the end of your surgery, where a thumbsical eye is replaced by a beautiful prosthetic eye, and you have a very similar superior sulcus on both the sides, and horizontal palpebral fissure sort of settles down to 1 to 2 millimeter of the normal side. So this is a good outcome of socket surgery. You do not see significant enophthalmos post-surgery. Now, as compared to this lady, let's take a little look at this gentleman. So this gentleman essentially has poor volumetrics. And why do I say that? So he is a person who again had, socket surgery on the left side. But if you look at his sulcus post-operatively, then you can see this deep superior sulcus in this gentleman. So what has gone wrong in his situation? In his case, the amount of volume that was imparted into the socket during the surgery is suboptimal, and hence he has this deep superior sulcus. So we know that surface loss is a marker for your contracted socket, like Roshmi beautifully showed with her photographs. So do you have a metric for volume loss? Yes, enophthalmos is one of the important metric that tells you whether there is volume loss on that side or not. And when you're assessing enophthalmos, it's always done with the prosthesis on. The second metric is superior sulcus deformity. So all these patients have a left prosthetic eye, and they have advancing grades of superior sulcus deformity. So if you look at this lady, the sulcus is very beautifully matched to the other side, and she has no sulcus deformity. As against that, this patient has a mild medial sulcus deformity, which is difficult to recognize. If you pay attention, you might find the difference on the medial side between the two eyes. Versus this is a definite medial sulcus deformity, a medial with central, and a medial central lateral, or a total sulcus deformity. So what does this mean? This means that this particular patient has good volume replacement in the socket, the first patient, and versus that the last patient has very poor volume reconstruction within the socket and hence has a gross superior sulcus deformity. So it becomes important for us to learn how to differentiate superior sulcus deformity from some amount of upper eyelid ptosis that might also be coexistent in these patients. Now, talking a little bit about why you need to place an implant. So essentially, this is a lady who's had a socket surgery without an implant. And what do you see? You see this concavity in the socket, primarily because there's nothing to build up the volume there. And then when she wears the prosthesis, like Roshmi explained, the entire vicious circle sets. And she has this sort of lower eyelid retraction, upper eyelid ptosis, and a deep superior sulcus. And what have we done for her? We've given her an implant, and with that you see that the eyelid goes back in position, the sulcus builds up in volume, which is what you want to see, and she's left with a little bit of ptosis, which can be corrected as socket surgery. So when you talk about a volume replacement, what is the ideal volume replacement? What is known to us is that 70% of the volume needs to come from your implant and 30% from your prosthesis. And you have several types of implants. You have porous implants where you're worried about exposure, and non-porous implant where you're worried about exposure, extrusion, migration, all the complications that you can see in an implant. But essentially, this is what you want to remember. So in an Indian patient, what this translates into is roughly a 20 millimeter or larger implant. Now, how do you place this 20 millimeter implant? So Dr. Jayanta has already spoken about several techniques, and I just wanted to show this one collage where essentially the amount of thiasis does not really dictate the size of the implant that you can place in, because you can release the sclera, you can perform sclerotomies, and you can easily place in a much larger implant and get a good cover over the implant so that you do not have implant extrusion. Now, what are the other ways of enhancing the volume? So this is a gentleman who has a very good sized implant, 20 millimeter implant place, but is worried about this sulcus. And all that we have done in him is inject filler. You can see the point of entry here. This is immediate post-procedure photograph. And you see the nice build-up in the superior sulcus. So you can do a secondary volume augmentation in the office itself with filler. Or if someone is desirous of a more permanent result, then this is a lady who's had a little bit of fat transfer into her superior sulcus to build it up and make it look more symmetric to the other side and reduce the sulcus deformity as you see in the preoperative period and reduce the enophthalmos. Yet another patient who essentially has a gross amount of surface as well as volume loss, and you see that large lower eyelid retraction, which is primarily because of this heavy prosthesis that he is using. And in his case, we've built up the volume by doing a secondary implant, and in the same sitting performed an MMG as well, and we were successfully able to reduce the thickness of the COP, and the eyelid goes back into its position once you have reduced the weight of the COP. And it's not only the weight, there are several parameters which are acting there. One of the important parameters there is the thickness. This is the same patient, the pre and the post thickness. And you can see that we've brought him down from 7.5 to about 4.5 millimeters of thickness of prosthesis, which has made such a large difference over eyelid. And probably last two slides. So this is another gentleman who had a infection. And you can see that he has this hypoglobic appearance of the prosthesis. And in his case, we've performed a porous wedge implant along the floor, no eyelid procedure, modified the prosthesis, a little change in the weight of the prosthesis, and he looks much better just with this. So when you look at any patient with socket, the paradigm that you should follow is look for presence of surface loss and volume loss, then assess if anything needs to be done to the prosthesis in terms of its thickness and weight, and finally assess the eyelids of these patients to see if they require any entropia or correction. Thank you so much.
Thank you so much, doctor. I am so sorry that we won't be able to take any kind of questions at the end of this session, as we are already about to start with the next session. So for the next session,
hello, hi, listen, Dr. Rahul Lokhande still has a case presentation. He's not finished.
Oh, so sorry, ma'am.
No problem.
Yeah, so we have Rahul come up to us with his interesting case presentation and panel discussion. Rahul, if you are here, can you share your slides, please?
Yes, ma'am.
Thank you. And we actually started this session around 4:15.
Rahul, can you go to full screen, please?
My screen visible, ma'am?
Yes. Go ahead, Rahul.
Okay. Good afternoon, everyone. I would first like to thank AIOS and Dr. Feroz ma'am for giving me the opportunity to speak. So today I'm going to present a case of contracted socket in a child, the journey. So contracted socket, as previous speaker has mentioned about, so I will directly jump to this case. So a 4-year-old child, male child, was referred to our tertiary eye care center with the history of right eye enucleation done elsewhere without implant when the child was 2 years old. The indication being right eye unilateral retinoblastoma. Post enucleation, the child received 9 chemo reduction cycles. Considering that they must have thought it would be a orbital retinoblastoma. But pre-enucleation MRI we have reviewed, it doesn't show any orbital tumor, and histopathological report also doesn't. It was not conclusive, and there was no history of post-enucleation radiation given to the child. So during the first visit to our clinic, our hospital, the child was put with a conformer and was asked to follow up at every 3 months interval. But meanwhile, the child lost follow-up and for the 2 years, and he presented to us after 2 years. So this is the clinical photograph of the child when he presented to us. Based on the Krishna classification, we can appreciate that there is superior and inferior fornices are shallow. There is deep superior sulcus. Medial and lateral fornices are very shallow. Surface and conjunctiva is healthy, but there is inadequate volume. So based on the Krishna classification, we have graded the socket as grade 3 socket going into the grade 4. So pre-operatively, we have done MRI. So this is the T2 weighted MRI, coronal section and axial section, which are showing extraocular muscle, which we can clearly appreciate, and there is no residual tumor. So what are the challenges in management of the contracted socket in a post-enucleation retinoblastoma children? So they are usually enucleated without implant, and absence of conformer, poor hygiene, and so low socioeconomic condition, and exposure of the radiation after the enucleation. But it was not the case in our case. So in 2011, our plan was either to consider a non-integrated implant with fornix formation suture, or to put a dermis fat graft with fornix formation suture. So considering surface as well as volume loss, we have considered a procedure of dermis fat graft with fornix formation suture, and we have also done the rectus muscles were fixed to the dermis fat graft to enhance the movement. So these are the surgical steps. I will not go in detail because previous speaker Dr. Rashmi ma'am has shown it in detail. So these are the steps from graft harvesting and putting. So the child after the procedure follow up at 1 week, 2 weeks. So at the second week, the fornix formation sutures were removed and the graft edges were healthy. This is the clinical photograph of the child after 6 to 10 weeks. We can clearly appreciate that fornices were well formed. Dermis fat graft and conjunctiva was partially vascularized. And this is the video showing the dermis fat graft movements, which are very good after the procedure. So post-operatively, after the 12 months, the patient followed up. So during this visit, we don't have any picture of the socket, but in this clinical photograph, we can appreciate nicely fitted prosthesis, but it was little bit larger size and it was non-customized one. So as per the retinoblastoma follow-up protocol, the child has visited every yearly from 5 years to 10 years, and this is a 10-year follow-up of the child, in which we can appreciate that fornices are well formed, dermis fat graft is well vascularized, and there is mild sagging. So after the 10 years when child came, Sorry. So these are the comparisons. These are the comparison of pre-operative and post-operative follow-up of the patient of 10 years. So coming to the conclusion, post-enucleation orbital implant should be the primary option. Management of the contracted socket in a child is challenging because both the socket and the facial growth are dependent on the orbital growth. Dermis fat graft is a viable option to treat the volume deficiency following enucleation or evisceration both in adult and children. Dermis fat graft continues to grow and act as a dynamic implant. It provides volume and its slow and constant growth may promote orbital development. Dermis fat graft is often only the promising option in cases of severely contracted socket in children, and it is an effective means of replacing orbital volume and affording motility to the ocular prosthesis. These are my references. Thank you.
Thank you so much, Dr. Rahul. It was great hearing from you with such amazing information.
Thank you, Rahul. Just to summarize our session, it was this case particularly sort of highlights the fact that never give up in socket surgery, and there's a lot that can be achieved if treated systematically. Maybe we'll just take a quick comment from Dr. Gagan before we hand over to the session to the next round of speakers. Dr. Gagan, the chairperson, if he's around.
Yeah, hi Tarjini. So
Hi,
very
Dr.
interesting talks, and we could actually give flavor of all the aspects, starting from evaluation and different techniques of management. Unfortunately, we don't have any attendees, but I believe all of us experience this patient, and it's a great learning from each other.
Thank you. So we are all set to hand over the session to the aesthetics panel now.
Thank you so much, Doctor.